mantle cell, I mean, we could talk just on one type of lymphoma, but let's just hit some of the major issues. With respect to mantle cell lymphoma, we know that it's maybe less than equal to about 6% of the lymphomas that we see typically today, and that it actually has a bad prognosis, which is changing. We're improving our outcomes. And what is the optimal approach to initial treatment for mantle cell? Oh, that's a $1 million question, and the issue is, how do we go about to utilize these novel agents? How are they used today? I think it depends on who's sitting on the panel now. If you're from MD Anderson, they're still using Rituxan hyper-CVAD, alternating the CVAD with rituximab, alternating with high-dose methotrexate Ara-C. We know that if we go, say, to Europe, there's a lot of combinations of R-CHOP, either alternating or sequentially using it with R-DHAP, which is the utilization of high-dose Ara-C. Cytarabine has made a major improvement in outcomes in our patients. The big question is that, in the relapse setting, we know that mantle cell single agent ibrutinib is really a game changer. And so with little toxicity, and it was presented by Michael Wong from MD Anderson, that in patients between 1 year of treatment and second year treatment, even though the objective response rate didn't change much, but they actually doubled the complete remission rate. So it is very interesting that things are, as we talked about in CL in more detail, rapidly changing. And some of the regimens that are just mentioned is that, do we use R-CHOP? Well, R-CHOP is not really a current. I would say that there is interesting, again, when you go and you panel, you go out and you send out a questionnaire. I didn't realize this, but attending some advisory boards, there's up to about maybe a quarter or more of practicing physicians use R-CHOP in their mantle cell lymphoma patients. And the issue there is that, well, some with or without, but a lot without, just starting their elderly patients in R-CHOP. Whereas the only thing I was mentioning is that, there's good data also that, if I had an elderly patient with comorbidities, I found that personally, although it's not FDA, R-bendamustine works great in these patients. And so I had one patient that actually had the polyposis, was actively bleeding with nodal disease, and was a very fragile 80-year-old. And with R-benda, not only did not have any perforation, responded, went into actually a CR with repeat colonoscopy, completely negative, with biopsies, blind biopsies, and bone marrow negative, and PET negative, and still remission. So I think that there is a changing time.
The Bright study actually showed that it favored bendamustine, rituximab in mantle cell, as in the other group. So again, it was
non-inferior from the Bright study.
It was a subset. You don't lose your hair.
One of the important issues with the mantle cell lymphoma is the issue of maintenance rituximab.
Yes.
And another, in elderly patients, when you're not able to give the high dose combination chemotherapy, then the use of rituximab had been shown to prolong the progression-free survival. Interestingly, there is a abstract in this ASH meeting for younger patients, so from European studies, where they used R-DHAP as the induction therapy followed by autologous stem cell transplant, and then randomized patient to rituximab maintenance versus observation. And they also observed even in young patients, rituximab maintenance in mantle cell lymphoma seemed to improve the outcome.
I believe, though, there's been a higher incidence of loss of CD20 expression altogether, which has complicated these strategies. It seems to be more prevalent in mantle cell than in chronic lymphocytic leukemia.
I think a striking thing, though, that in our practice at OSU has been the subset of relapse patients that get a good response to ibrutinib and get out. While the median response duration was, I believe, 17 months in the initial phase 2 by Michael Wong. There's a subset of about 35-40% of patients now on that study and others that are they're just in continued remission. So you're seeing what you never saw in mantle cell before these targeted agents was a plateau. And again, it's a short plateau, but we'll take any plateau in mantle cell, and that's really been something very exciting for patients with mantle cell, I think.
And it's going to be important to identify who those patients are. I mean, of course, the median PFS won't take into account this plateau. But it really is, as you mentioned, that there were these patients whose responses improved very late from PRs to CRs. Absolutely. And those are those patients who are part of this plateau. And I think that one of the important questions related to mantle cell is going to be this question about when the patients not just develop a blastoid mantle cell, but when their mantle cell really becomes highly proliferative. And there is an abstract at the meeting talking about the use of Ki-67 as a predictive factor in outcome in mantle cell. It was actually more predictive than histology. So I think, the question for all these novel agents, which seem to work very well, is, whether or not, when these cells become highly proliferative, whether or not that's where we're losing our efficacy with these agents.
Sure.
And if we can get these agents in earlier, before the cells develop that transformative process, that makes them so aggressive, could we obtain long-term control?
But we all realize that